A very good morning to you all. My name is Upendo Mwigira. I am the Senior NTD Advisor from the USAID End NTDs program, which is led by RTI International. I will facilitate this webinar with the support from my colleagues, Megan Meekins, who is the Senior Communication and Knowledge Management Specialist, and Aria Gray, who is the Senior Communication Specialist, who will mostly be at the background. We are very happy to welcome you to our webinar titled Reaching the Criteria to Stop Onchocerciasis Mass Drug Administration, Ethiopia, Nigeria, and Uganda Pave the Way, which is hosted by us, team, End NTDs team at RTI International. Before I do so, I would like to give you a big thank you to the Carter Center, our consortium partners, along with all speakers and panelists for the incredible work to organize this event. The thoughtfulness and the attention to detail I've seen for this particular group is truly remarkable. As most of you know, the commonly known river blindness or scientifically known onchocerciasis is one of the neglected tropical disease that is spread by black flies, and it is mostly in areas where there are fast-flowing rivers and streams. If left untreated, the person may develop severe itching, rashes, depigmentation of skin. The filarial parasite can migrate to the eye as well, and then can lead to visual impairment. Onchocerciasis is one of the eliminable disease, which is categorized by the recent WHO roadmap. And recently, the WHO monitoring and evaluation framework has also stipulated very well the indicators for onchocerciasis, which includes that number of countries that stop MDA in one or more focus, number of countries that have stopped MDA in 50% of the population, and so for the 100% of the population. So national programs have been implementing the onchocerciasis programs for many years, and they have faced significant challenges in getting to a point where it is possible to stop MDA. While these circumstances are different and unique from each country, many of the countries have encountered specifically the challenge of reducing the transmission to the point that it is being able to stop the treatment, refining surveillance methods to ensure that they are capable to both implement effective programs and provide accurate assessment of human as well as vector infection levels, and ensuring financial resources, political support, and community participation. So Act to End NTDs program has learned these valuable lessons through supporting various countries to reach this MDA milestone in their journey to achieve the elimination of onchocerciasis. And this is what brings us here today. In today's webinar, we'll hear how Ethiopia, Nigeria, and Uganda have been able to address these steps of elimination, and hence provide other countries examples towards working to stop onchocerciasis mass drug administration. We're very excited to have this event today, and we thank you all for being part of this. And with that, I will hand over to Dr. Frank Richards, who is the Senior Advisor for River Blindness, Lymphatic Filariasis, Schistosomiasis, and Malaria programs from the Carter Center. Welcome, Frank. Before Frank comes, sorry, I would like to let you know the norms and agenda. Please, Megan, go back to one slide before. We would like you to have posted your chat in your questions in the Q&A, making sure that you have posted them in Q&A, not in the chat, because this is a webinar. And also, before you put your questions question, please introduce yourself or flag the technical difficulties if you have one or any, and raise your hand if you have any technological issues. Thank you and welcome, Frank. Yeah.
Thanks very much, Upendo, and good morning, good afternoon to colleagues and friends in the audience. I'd like to say that this launching of the End NTDs East technical brief for reaching the criteria to stop onchocerciasis MDA will look at examples that have led to over 6 million treatments being stopped overall in Ethiopia, Nigeria, and Uganda. On the red box in your screen, you can get the context of what we're going to be talking about and what this brief deals with. It deals with identifying or mapping areas. It deals with treating people with high treatment coverage for at least 13 or 14 years if it's an annual treatment process, shorter if it's twice per year, or engaging vector control, conducting post-treatment surveillance after MDA has been stopped, and then conducting post-elimination surveillance until a country has completed all of its transmission zones. It's important to recognize that these 4 steps, while they're consistent in one transmission zone in a linear fashion, can be going on throughout the entire country in different transmission zones at a given time until all foci have reached post-elimination surveillance, when the dossier can be written and the verification process can take place. I'd also like to emphasize that this is elimination of transmission, not elimination of a public health problem. And in the current roadmap, the 3 NTDs scheduled for verification of elimination of transmission are onco, African trypanosomiasis, and leprosy. Next slide, please. Now, here's the life cycle. On the right of Onchocerca volvulus, it goes clockwise. It cannot go counterclockwise. On the left are the human stages of the parasite. On the right is where the rubber meets the road as far as transmission is concerned, and that's on the vector side. So in terms of diagnostics, we all recall that nodules, which is where the adult worms are, nodule rates were used as a way to map onchocerciasis in the APOC days. Next, the adult worms produce microfilaria, which could be diagnosed with the skin snip. Next, please. And in the past, we were using dissection to look for L3s in black flies. Now, PCR is used on the heads of black flies to get at the L3 larvae. And if that is multiplied times the biting rate, you can get the annual transmission potential, which is the force of transmission of this transmission cycle. Next, please. Now, the OB16 antibody, it's an antibody, not an antigen, so it can look for infection, previous infection, or exposure, is now a very important tool for monitoring transmission. And because it's an antibody, it needs to be looked at in children for evidence in recent transmission. Next, please. Now, the OB16 antibody, the PCR, ATP, are important parts of the current onco paradigm and the 2016 guidelines. And they have replaced nodule rates, skin snips, and dissection of flies. But they also indicate that rather than field assessments, we also need to have laboratories supporting the OB16 ELISA as well as the O150 PCR. Next. Okay, so in a given transmission zone, this is the linear progression schematically. Starting on your left, where the force of transmission, the ATP, and the adult worm population is at 100% of the starting point, baseline, you start mass drug administration and you progress through phase 1 and phase 2. At the end of phase 2, next please, you can stop MDA because the adult worm population has reached a point where it can't recover. Next please. Then you go into post-treatment surveillance, which is very important to look for recrudescence, which is essentially done entomologically to see if that ATP line on your far left starts to come up again on your far right. Then you move to confirmed elimination of transmission and post-elimination surveillance. Next, please. In the maps, the consistent things that you'll see in the next presentations are red, which indicates that the right side of the transmission cycle I showed you is active and still going on. That is active transmission. And next, please, green, which is when you've reached elimination. So those are the stages, those are the colors you'll be seeing in the maps. The countries have used all sorts of different colors in between the red and green based on what their committees believe is best for demonstrating the progress of the programs. And with that, I will turn it over to Upendo and to introduce the next speakers. Thank you very much, everybody.
Thanks a lot, Frank, for the very good introduction. I'm now going to introduce our three speakers from the three countries, starting with Ethiopia. We have Dr. Tedese, Dr. Derihun Tedese, who is an expert of public health with 3 decades of experience in patient care, public health management and leadership. He earned a Doctor of Medicine from Addis University, Uganda College of Medical Sciences in 1991, and then a Master's in Public Health from School of Graduate Studies in 2004. He joined the Carter Center in 2009 and served the 2.5 years as a director of programs. And in June 2011, he was appointed as a country representative of the Carter Center. This is Dr. Tedese. The presenter from Nigeria is Dr. Mary Emmanuel, who is a medical doctor and a public health physician. He joined the Carter Center since 1996 as the country representative to date. He directs the Carter Center Neglected Tropical Disease NTD programs in Nigeria. In 2013, Dr. Mary was honored with the prestigious award of the Officer of the Federal Republic by the Nigerian president. Then we have a presenter from Uganda, Peace Habomugisha, who is a social scientist. Peace joined the Carter Center in 1999 and became the country representative since then to date, since 2003 to date. She is leading the Carter Center effort to eliminate onchocerciasis in Uganda. And between 2014 and 2018, she coordinated different NGOs to eliminate trachoma as a public health problem. Welcome our three presenters, and please note that their presentations are pre-recorded, so most welcome to listen to them. Thanks.
Hi, everyone. In the next few minutes, I'm going to share with you a report from Ethiopian Onchocerciasis Elimination Program, which dates back to 2001. During the first decade of the battle against onco, the strategy was onchocerciasis control. Mapping was done by nodule palpation. Here we see prevalence presented for sites in the west third of Ethiopia. Based on the prevalence of the disease, we see spectrum of sites that span from non-endemic to hypo, meso through hyperendemic areas. For over a decade, the service was limited to small part of the country, worst affected by the disease. For Ethiopian onco control program, this period can be referred as decade of crawling. The next slide will depict clearer picture of the same sites. Onco flux in 2008 and 2021. At baseline, it was thought that onco was endemic only in west third of the country. There were only 4 categories of districts, namely those that were endemic, those to be refined, those which were non-endemic, and the 4th category which were excluded, the rest of the country. It was that simple, And that was more or less the case until the ministry launched onco elimination back in 2012. That time, I remember when Frank Richards of the Carter Center felt disappointed on repeat occasions when presented with same map year in, year out. To everyone's relief in general, and the affected communities throughout the country in particular, after 2012, there was gear shift from control to elimination, and the categories by which we monitor progress of onco elimination gradually increased to 7, especially after Ethiopian Onchocerciasis Elimination Expert Advisory Committee, EEAC, and the Carter Center Assisted Molecular Lab at EPHI were established in 2014. Right now, Onchocerciasis Elimination Program has a wide spectrum of districts in different phases, namely endemic on M-Day, endemic but not on M-Day, which are located in different parts of the country, those which are on PTS, which will be the focus of our discussion later, and others which are being mapped, which means DBS is collected and is being analyzed. And we also have some pockets of areas which are not mapped. And we have also areas which are unsuitable for onco-transmission based on entomological assessment. Even though the onco map kept on expanding north, east, and south, still most of the endemic districts are located in the west third of Ethiopia. Onco elimination mapping in north, south, and eastern part of Ethiopia is yet to be completed. Despite incomplete information due to ongoing elimination mapping project, the contrast between these two maps clearly demonstrates the great accomplishment registered during the last 10 years. This period can be referred to as a decade of rapid expansion, refinement, and mastery. It's also a decade marked by simultaneous scale up and scale down. Now, allow me to take you to a remote location along the border between Ethiopia and Sudan, which is called the Galabat-Matamma focus. Galabat-Matamma focus is unique for the following 3 reasons. One, it's the first cross-border focus in Africa where transmission of onco was interrupted through coordinated effort between Ethiopia and Sudan. 2, treatment was stopped despite identification of Udigam's hotspot as the heart of the special intervention zone. 3, the exemplary communication and coordination between the two countries contributed enormously to the success of the project and hence uniqueness of the focus. This brief presentation attempted to cover a story of a cross-border transmission zone. That said, what are the lessons one can draw from this special project? Lesson number 1, as complicated as it might be to deal with a disease that crosses international border, the challenge didn't stop the two countries from making interruption of transmission a reality. In fact, the first area where transmission of interruption is heralded in Ethiopia happened to be in an otherwise least likely place where cross-border migration of people and or black flies could have complicated the situation and ended up in protracted program implementation. Lesson number 2, a buffer zone that separates one transmission zone from another is identified, and the buffer zone helps to pick early signals of recrudescence and by so doing prevent introduction of imported infections from an area with ongoing transmission. Lesson number 3, in any focus, stop MD is not necessarily straightforward yes or no decision. Instead, there is also middle ground where MD stops in some areas but not in others. This flexibility helped us to strike delicate balance between shrinking the map and not leaving any sites unattended. The intervention on the hotspot will put an end to transmission of onco throughout the focus. I thank you for the opportunity and welcome any questions or comments.
Good morning, good afternoon, and good evening to you all. The Nigerian Onchocerciasis program started as a control program, but in 2015, the Federal Ministry of Health decided that it was no longer going to be a control program, but an eradication program. In 2015, the status of transmission in the 36 states and Federal Capital Abuja were as follows. The 11 blue states on the map had no data or information on the status of the onchocerciasis. The 6 tan states had their transmission suspected to have been interrupted, while the 12 yellow states were states that were said to be on track for elimination by 2025. And the last 8 states had their transmission ongoing. But by 2017, 2 out of the 6 tan states had changed from tan color to ash color, meaning the transmission had been interrupted in these 2 states. And in May 2021, the Nigeria Onco Elimination Committee met and recommended to the Federal Ministry of Health that these 2 states, Plateau and Nasarawa, should move from ash color to green color, meaning transmission has been eliminated. If approved, these 2 states would be the first 2 states to achieve this feat in Nigeria, where elimination has been achieved. Then Nigeria is currently estimated to be over 190 million in population as 2020. It is currently projected that over 50 million Nigerians are at risk of human onchocerciasis, and so the largest at-risk population in the world. The 2 states, Plateau and Nasarawa State, had achieved the status of tan color in 2017. This means that by implication had stopped giving treatment to over 7 million residents in these 2 states. In 2015, the Federal Ministry of Health inaugurated the Nigerian Onchocerciasis Elimination Committee to support the federal government's effort to get the entire country to reach the status of transmission being eliminated, and thereafter position the country for verification by WHO. Some of the lessons learned from the Nigerian programs are: 1. The use of black fly trap technology to make stop MDA decision possible. The conventional method of using human bait was not yielding sufficient number of black flies required per transmission zone, and hence the need to introduce this new innovation, which the Nigerian Onco Elimination Committee approved its use. Because of the integration of lymphatic filariasis and river blindness program in these 2 states, regions that were hypoendemic for river blindness and therefore did not qualify for treatment were now being treated with albendazole, ivermectin, because of the lymphatic filariasis program. This integrated approach for MDA would give the program the opportunity to also conduct an integrated LF and OV surveys. Thank you for listening.
Uganda's presentation on onchocerciasis. This slide shows the status of onchocerciasis at baseline of elimination in 2007 and the current situation. In 2007, when the government of Uganda launched elimination, most of the foci were in red, which meant transmission was still ongoing. It was only 1 focus where elimination had taken place and 2 where interruption of transmission was being suspected. Currently, only 1 small focus in southwestern Uganda, bordering DRC, is where transmission is ongoing. The rest have either eliminated the disease completely, others are in their post-treatment surveillance that have stopped MDA, and mid-loss, one focus, a big one, is where interruption of transmission is being suspected. Background to onchocerciasis in Uganda. Control of onchocerciasis started in early 1990s and elimination began in 2007. To quicken elimination process, cross-border collaborations were established in DRC in 2008 and South Sudan in 2018. All hypendemic communities were included in the MDA program. So far, 15 foci have stopped MDA. That is, as I said earlier on, 8 have already eliminated the disease and 7 are in their post-treatment surveillance phase. Key lessons. High MDA coverage complemented by using ground herbicide and the slash and clear quickened elimination. Ground herbicide with abate eliminated Sumerian flies in 9 foci, which accelerated the elimination process. Community self-help slash and clear reduces vector population and increases the impact of biannual treatment with ivermectin in eliminating transmission. Political support is key to program substantiality and elimination. Uganda government is very supportive. Celebrating progress at the focus level reinforces the success of program and reminds the affected communities and their leaders that they are no longer at risk of acquiring the disease and can plan their future with confidence. Thank you for listening.
Thank you, our presenters from the 3 countries. Now, I would like to welcome Professor B.E.B. Nwoke from Nigeria. Professor Nwoke is the Professor of Public Health, Parasitology, and Entomology at the Imo State University, Owerri in Nigeria. He has nearly 4 decades of research experience in different aspects of endemic parasitic diseases and their vectors, especially neglected tropical disease. Currently, Professor Nwoke is the chairman of the Nigerian Onchocerciasis Elimination Committee. We also have with us Mr. Kadu Meribo. Mr. Kadu Meribo is a public health specialist and currently the National Coordinator for Onchocerciasis Elimination in Ethiopia. Please welcome. And we will be also joined by Dr. Moses Katabara here, who is working with the Carter Center Atlanta as an epidemiologist. Please welcome the 3 of you to join us. And what we are going through now is the reflections from the presentations. And please, can you join us? Professor Nwoke, I'll start with you. You being the Nigerian chair of the National Onchocerciasis Committee, please tell us more on the elimination efforts in Nigeria and commitment from the country, as well as what is the role of the National Onchocerciasis Elimination Committee.
Thank you. Thank you very much. The role of the panel or NOEC committee is designed to be the technical arm of the elimination process. And when we started in 2015, we had to sit down and develop strategic plan on how to handle the elimination process. We try to appreciate where we are now, where we do want to go, what instruments we need to go with. Where do we want to achieve? What do we want to achieve? How do we want to achieve them? That helped us to develop, and we went into the field and collected all historical data concerning onchocerciasis in Nigeria, placed them at the table, analyzed them, and developed stage by stage, state by state, transmission zone by transmission zone, and then we created a color for them as was presented by Dr. Miri. We also went ahead to put in place all the necessary documentations, like creating a guideline for Nigeria, taking into consideration WHO guideline. And we had a lot of training, both entomological and epidemiological training. And we jointly at one point chose all the breeding sites for sampling, all the communities, and developed research, including research on Loeluasis and its possibility in cause of the elimination. So far, so good. We also had a problem of cross-border, and we went with Cameroon and Benin, and we are doing very well with them. Currently, we are trying to get the villages and their heads in the Benin border, and if not because of the pandemic, we should have handled it. And along the line also, we encountered the insecurity and movement of people, and we decided to develop a strategy of going to the settlements and training the people who are there and create their CDTs and create their distributors, and we'll be handling them. So far, so good. I'm pleased to inform us that we have up to 10.2 persons, 10.2 million persons that are now out of the Metizan. In Plateau State and Nasarawa, there are 12 local governments here, and we look at about 2 million people are now out. In Kaduna, 2.2 million are no longer taking the Metizan. So also in Zamfara and Kebbi, 4 million. And in Delta State, 2 million. So we are proud to say that with 10.2 million people are now out of Metizan in Nigeria, and we have already written to the Federal Minister of Health, the Minister, to cause celebration of this, to encourage other people that elimination process is doable even in Nigeria. We are looking forward that by 2023-24, we should be able to have done all the entomological and empirical evaluation and try to look at the possibility of eliminating onchocerciasis transmission in the next 4 or 5 years. We are doing very well. Whenever we see a hotspot, we increase the number of times we treat them. And we are pleased to say that we are doing very well. Government is supporting us, even though they are not at the peak. But we want to thank all our NGO coalition, the United Nations program, and all the persons who have helped in doing this. The local governments and communities, they've been there for us. I want to thank you for inviting us to contribute and share. I'm very open to take any discussion or questions. Thank you very much.
Thank you very much, Professor Nwoke, for very good elimination progress summary of Nigeria. And we are very proud of the efforts so far. Now going to Ethiopia, Mr. Kadu. In your presentations, you had a peculiar explanation on the aspects of cross-border. And that is being very, very much a challenge in most of the countries. So can you please tell us more about that and also add some more insights of elimination progress of onchocerciasis in Ethiopia? Welcome, Mr. Kadu. Mr. Kadu, are you there?
He's muted. Good.
Can you unmute, Mr. Kadu?
Hello?
Yes, you're
Hello?
welcome. You're welcome.
Hello. Yes, yes. Thank you. Cross-border area covers especially Galabat and Matama. Galabat Matama focus, large area. And Ethiopian side, Matama sub-focus, which hotspot located in. Because of this, in 2014, we established the cross-border collaborative team to work together to review cross-border area activity, especially with particular reference to onchocerciasis elimination and lymphatic filariasis elimination, then to develop plan of action to work together to move forward on the same pace to stop MDA. And as a result of this cross-border effort, in 2018, two countries, Sudan and Ethiopia, at the same time stopped MDA in cross-border area, large focus Matama Galabat area. And this cross-border collaborative effort continue. And in 2020, including South Sudan, we conducted a cross-border consultative meeting in Ethiopia, Gondar in Ethiopia. And in this meeting, we developed plan of action to work together to move forward on the same pace to eliminate onchocerciasis in this area, and in future to celebrate together elimination of onchocerciasis in this region. The hotspot area with the Gamzu located in this area, and based on our national onchocerciasis elimination expert advisory committee, as previously presented by Dr. Zarihun, we identified that area as hotspot, and including the Matama sub-focus, we established a buffer zone between other transmission zone and an area under PTS, and we divided that area Matakalawi focus and Matama sub-focus. In between two focuses, there is a buffer zone. So our elimination based on a recommendation of Ethiopian onchocerciasis elimination expert advisory committee. As per the recommendation, we are going to move forward. We working with our neighboring country, Sudan and South Sudan, to eliminate the onchocerciasis in this region. Thank you.
Thank you, Mr. Kadu. And now I would like to, please be reminded, you can post your questions to the Q&A space here. We discourage using chat, but you can post your question in the question and answer, all of you. So after hearing from the two countries, now Moses, welcome. And do you have any comments to add on with regard to OV elimination in Africa? Please welcome Moses.
Thank you. We have a tough parasite, and it comes in different shapes and how this parasite works. You hear sometimes they refer it as a blinding strain. So it comes in different strains, and it comes in different ecological settings and in a changing political environment, and even the donor environment. That's Africa. So thank God we have ivermectin that is free and safe. But what I've just said means that we need to be flexible in what we are doing if we want to achieve elimination. We have to think about in some areas moving from annual treatment, which we have done for many years, to biannual treatment, depending on the situation in that particular area. And WHO, the World Health Assembly has a recommendation, or rather has a resolution on vector control. And there's a document, WHO document on vector response. So we have more tools to use. And we need to look at each area or transmission zone and think how to deal with this instead of thinking, okay, we'll do it annually for the next 13 years or 6 years or what, because in the real life, it doesn't happen that way. Because sometimes management is not that good, so you don't get a good coverage. And sometimes people are displaced because of civil strife and they miss their treatments. So we need to be aware of this environment in which we're operating. The second thing we need to think about is laboratories. How many countries have laboratories, or endemic countries have these laboratories with PCR capability? It's not damn expensive. It can be done, but the countries need to know that it's not expensive and it's doable. Entomologists, you need to analyze Samrian flies, but there are many species of Samrian flies and not all of them are vectors. So are you going to get any fly and take it to the lab and analyze it and then say, if you don't get DNA of Onchocerciasis and you say, oh, I've done it, when actually you have only picked and analyzed non-vectors? And yet Africa has a problem of entomologists. This was done some time back in structural adjustments by World Bank and others. And now those vector control departments are not there in most endemic countries. And so we need to build that capacity. It's not difficult to do it. We can do it. Then the other thing we need to think about is to be creative. We need to look at the transmission zones, map them, because a number of times we have lumped up everybody and we are now treating 5 million people in an area when actually there could be only 1 million. So our efforts to treat 4 million extra is just taking up our energy and resources. And so it is better to look at the transmission zones. And so when you eliminate, you know that you have eliminated. So you can actually separate the transmission zone. There is no blanket cover transmission in most areas. So they are buffer areas. Why not identify, as Ethiopia has mentioned? So that's very important. Another thing, when you are in elimination, expect surprises. We are dealing with situations where they could be lower, and you are not expected to treat with ivermectin in such areas. So what do you do? Maybe this is the time to think about vector control. Is it slash and clear? You can use slash and clear. It can be done by the communities as long as they know that there is a fly that is biting them and keeping them from their gardens. And the black fly or the Samrian flies in Kiswahili, they call it umbwa, bites like a dog. So the communities that are experiencing those bites don't like it. So they can actually participate in reducing the population of this vector using slash and clear if it's done in a smart way and people are educated. So creativity, expecting surprises when they happen, we shouldn't be surprised, but we should learn how to identify these surprises and deal with them. I think that's what we need. Thank you, Opendi.
Thanks very much, Moses. And that summarizes what others have said, and I really appreciate your contribution. So now I would like to welcome the rest of the panelists. Our speakers now will be live as well, starting from Dr. Frank Richards, and then the country presenters, and our reflectors from countries. Please all join me, and we'll be answering questions live, but the ones which are typed in the Q&A. So please, we encourage you to type your questions in the Q&A, because we will be answering one by one, and we'll try to take as much as possible of most of the questions. We will be answering live at the beginning, and not getting the questions live. So if you have a question, please type in the Q&A. I've seen here a question from, it was most of the comments by Maria Gloria Banzanes, but the next one comes from Gabriel Matwale. The question is to Nigeria. States like Obum, with no data bordering Cross River, which is highly endemic. Any plan to collect data from such states?
Thank you very much. As you know, the program is expanding, and one of the handicaps we had was getting NGOs who are interested in working in those states. Right now, as I speak, we have an NGO that has been assigned to Akwa Ibom and would be doing this collecting data so that we have information. Just recently, as the chairman of the NOCE mentioned, at the last program, at the last NOCE meeting, Jigawa, one of the states that is up in the north, also in the blue state, we got an NGO to give us data that they have collected, and the state was reclassified. So we are working on that so that all the blue states, the 11 blue states, we get data for us to be able. The NOCE cannot position the country for WHO certification until we have data for all the states. So yes, the answer is yes. We're working on that, and very soon we'll have data for those Akwa Ibom in all the 11 states that are blue. Thank you.
Thank you very much, Dr. Miri. We have another question to Nigeria as well, from Maria Gloria Bazanes. For Nigeria, how is the difference between elimination and interruption of transmission defined?
Thank you for that question. The categories are defined just as in WHO. It's a copycat from the WHO guidelines. It's not anything different. All you need to do is to do the ELISA test, OV16 ELISA test on children less than 10 years, and also on the black fly PCR on the black fly. And based on the results, you can now place the country in the different categories. But I want to assure the person who has asked the question that the Nigeria guideline is not different from the WHO guidelines. Thank you.
Thanks again. Now we go to, I think this is a general one, and it's about the Onchocerciasis Elimination Committee from Dr. Mike French. The Onco Elimination Committees can have important lessons for similar committees for STH and Schisto. What has made them a success, and what has been the challenges?
Yes.
Professor, yeah, you're the best one to answer.
Thank you very much. I want to appreciate Dr. Miri for picking up those answers on our behalf. In NTD, we learn a lot of lessons from other disease programs. Their integration is a lesson. Using the same people that are working in Schisto as a CDTI persons at the end of the road is also a lesson. Also, making sure that they are chosen by the communities that are the people who distribute is also a lesson. Along the line of this elimination program, we encounter a lot of challenges, and we adapt to it and develop research to answer them. Sometimes we encounter poor geographical coverage, and we go back and re-mobilize the people and handle it appropriately. In some areas, we have conflict where people leave their homes and move out as a result of insecurity. As I said, we now move into those areas where they are settled and mobilize them and train them so that they will take our drugs and other NTD challenges they can handle. Cross-border is a challenge, as I said, and we are handling it because we know that WHO is also helping us on it. There are sometimes some transfers of our staff, when you train them for some time, in the ministry, they move them out. We have to retrain them again. But we now take a decision and mobilize the ministry people not to over-transfer our colleagues after training them. Sometimes we are faced with frequent inability to have a full 100% support from the country or local government or state. We now go ahead and do high-level advocacy and make sure that they come up. Sometimes we have the challenge of some of our CDTIs or CDDs demanding for money to do their work. We do advocacy. We now use some of the CDDs who are in other programs where they are having incentive as our own. And we also involve more women because of their passion and their role in the family. They now help us to make sure we don't overspend on doing that. Sometimes compliance, especially in these new areas where we have cleared, where we have seen elimination and interruption, they no longer suffer any of the clinical manifestations. So they tend to be relaxed in taking the drugs. So what we are doing in Nigeria is to develop a new IEC work, remobilize them, and then I think we are getting tremendous result. We tried it in Plateau and Nasarawa, and we know that we have done very well, and the people are cooperating. These are some of the challenges we face, and we'll be able to handle them. Thank you very much.
Thanks very much, Professor. And please, we have additions from Ethiopia. Can you add, Dr. Zerhun?
Thank you so much. Few pointers on the success factors for the expert advisory committees. Top in the list comes government ownership, followed by partners' commitment, technical, financial, and otherwise, and dedicated contribution of global experts. This is voluntarism. This is like the highest, CDDs at the highest level. The CDDs provide service at the community free of charge in their village, but our global experts fly all the way to come to us and provide free service. So these are again our heroes. Then the very fact that this is an elimination program is exciting. Everybody comes to the meeting to count the number of districts which move from one phase to another. This is like the day we used to collect report cards. It's very, very much exciting. Challenges quickly. This is an activity that needs year-round follow-up. There is no way for us to cook it overnight and present it to the expert advisory committee. So this is a big commitment by the government and the experts in various areas. The other challenges, the experts are in different time zones, and working together is not an easy task. That again is very challenging. Not all partners contribute equally to this partnership exercise. That again is a challenge. Despite all this, the most important thing is the success is weighs heavier than the challenges. So great lessons for other NTDs. Thank you.
Thank you very much. And I see a hand raised by Dr. Frank, please.
Thanks, and thanks for the questions. You know, I really agree with what a number of people have said about the importance of political support and advocacy. I know my friend at the Mectizan donation program, Yao Sotalone, often says, make a big noise. And I really appreciate, thanks Professor BEB for pointing out the 10 million MDAs stopped, treatment stopped for onco in Nigeria. I mean, that's major. And so often we hear about all the MDAs being stopped, all the treatments being stopped for trachoma, all the treatments being stopped for LF, and people are wondering, well, you know, what's going on with onco? And so I do think this this technical brief and the successes in these three countries, taken together with the successes in the Americas, where 94% of the treatments have been stopped, are all indications that we can do this. We can stop onco, and but we need to make a big noise. There needs to be political support, and there needs to be advocacy. And I just encourage folks to follow the approach used by Uganda. Congratulations, Uganda. Congratulations, Peace, Ministry of Health. Every time the National Committee meets, at the end of the National Committee meeting, the Minister of Health meets with the press and gives an update. And then there's an article in the newspaper about the progress. And that, you know, I would love to see that in Ethiopia. I would love to see that in Nigeria. I would love to see that in the Americas. Making a big noise and celebrating is such a key advocacy piece, so that people believe that this can be done, and this process will work, because there are a lot of naysayers out there in what's happening with onco right now. Thank you very much.
Thanks very much, Dr. Frank Richards. I don't see a hand of the panelists to add on, but let me go to another question. We have one from Lisa Rotondo. She's saying, greetings and thanks to the presenters and panelists. She would like to hear more on the operational aspects of developing the cross-border spatial zone. Were there many memorandum of understanding or legal agreements across countries, or has it been more informal agreement? Colleagues from Ethiopia, Dr. Tadesse and Kadu, please welcome to respond to this.
Maybe Kadu would be best positioned, but as far as my knowledge goes, there is annual meeting among East African countries who discuss on health matters, NTDs included. So this cross-border is run under the framework of that agreement among the ministries. And for the last 5 or so years, we have been doing the cross-border meeting between Sudan, Republic of South Sudan, Ethiopia. So this has been the trend over the last couple of years.
Thank you. Any addition from Kadu? If not, then let's go.
No, I don't have.
Welcome, Kadu.
From Nigeria?
Yes, from Nigeria.
Go ahead. From Nigeria?
Yes, you can respond. You can respond, Professor.
Thank you very much. In 2007, WHO Afro had a resolution of inter-country relationships in the control of some of these endemic diseases. So we took advantage of this WHO resolution in 2007, and we've been in contact with Cameroon. We have had 2 or 3 meetings with them. We have created strategy for handling the cross-border issue. For the Benin, we have already done some work with them on the rivers that transcend through the 2 countries, and results are very impressive. And we are working to have a second meeting, if not because of the pandemic. So we are doing very well in that. And we believe that with this year and next year, we are going to finalize it. But yet, there's no MOU. But we are taking advantage of this WHO resolution, AFRO. And I don't think we have any problem. We have invited them 2 times to Nigeria during our meetings. We've been there once in their own meeting, and we are sharing ideas and strategies. And I think we are doing very well. Thank you very much.
Thank you, Professor. Going to Uganda now, Maria Gloria Bazanes has said it is important to understand the impact of combined vector control and ivermectin MDA, as it was increased, there was an increased frequency of MDA. Can you comment on that, please? Unmute.
My hand was in the cross-border, but maybe I can go ahead.
Yeah, you can.
My head was in cross-border. Can you ask the question now?
Yes, you can combine the two, the cross-border, and then the other was the impact of combined vector control and ivermectin MDA.
Yeah, the cross-border issue, I think, for Uganda has been a success. The process is the cross-border districts usually have contacts with the cross-border district across the bordering countries because I've been having activities like polio, like all that, the Ugandans are crossing over. So it did not become hard to invite the Congolese to come and attend the meetings. And in such meetings, then side meetings are done, and then they discuss about cross-border problems. But sometimes the only challenge, especially with DRC, comes when we have to contact the Kinshasa government, and then they are slow to respond, like to writing letters and all that. But meetings have already been done. And with South Sudan, Juba is very supportive, it's just very quick to respond. We have had meetings with them, 2 meetings, and the Uganda government people have crossed over into South Sudan and worked closely with the South Sudan on vector control, on vector prospection, river prospection, and had started, and the fly catchers were put in place. Only this now pandemic is the one which has stopped the activities in these areas. Also, Uganda has helped with ABET. It has crossed over to DRC, the Uganda government, and they have done some dosing of the rivers. However, I think they need to get permission from Environment Department of DRC so that they could continue with activities. But otherwise, cross-border activities have been ongoing. And that is why in many places, if you look at the map of northwestern Uganda, we have eliminated because of the collaboration between Uganda and DRC. Control of vectors, Uganda has used, it depends on the vectors. Uganda has 2 different vectors. One is Simulian nearby, whose flight range is very near, about 4 kilometers. And here we use it a bit to spray in the rivers. And it has seen many fossil being eliminated of that disease. But where we have Simulian damnosum, this is just a control to just reduce the number, the vectors, but elimination is very hard whether you're using a bit. However, there is a new strategy called thrash and clear, where they are thrashing the vegetation that is touring in the rivers, and the results are very good. And we hope, because this is a community initiative, once the community members have accepted and have briefly did, because they are seeing the flies being, biting them. And when they did the thrashing, the flies disappeared. And then later they see them come back. Then they take it up, that been taking it up, and we have started with it, and we are seeing how it can be continued. But it's a good strategy, because eventually we believe that the flies will be eliminated using thrash and clear. Then MDA, we really, it is having just a good coverage and making sure that everybody who is eligible, at least 90% of the eligible population and above, are treated. And these who have been maintaining this through using small divisions within the community, where the distributors work within those small divisions. And then once you get that different divisions, they make a community, and then you find that the coverages are really high. So when you have high coverages, and then you have reduced the vector part, or you have eliminated it completely, then onchocerciasis elimination is possible.
Thanks very much, Peace, for the double share of the questions, response. So thank you very much. And I think there's been a lot of some more questions on cross-border, and colleagues have tried to explain more on this. And in case there is anything to add, Moses, I see your hand, please. Moses, welcome. Unmute.
Muted.
He's
I
muted.
thought I'd done it. Yeah. So as far as larviciding is concerned, it depends on the focus, on the onco focus you are looking at, and so there are varying foci where you cannot really easily eliminate the vectors. But there are cases where vectors have been eliminated. So one has to understand your kind of the focus you are talking about. For example, Victoria Nile focus was Samurium daminosum focus, but it was the vector were eliminated. But Mid-North, which is northern Uganda, is not easy to eliminate the vector, because they are national parks with animals, and where you cannot go there, they are breeding there. So there's a lot of factors that make that difficult to eliminate. I want also to mention something on cross-border. All these African countries have bilateral and multilateral agreements that accept cross-border activities. The only issue is putting this in action. And then also there's something very interesting about Africa because of our history of colonization. Some tribes were divided into two. You find one tribe in Ethiopia, another, it's the same tribe in Sudan. Or in the case of Uganda, you have tribes speaking the same language across the border. So also exploring the local administrative institutions across the border helps a lot, because they are the same people, they have the same problem, they can put pressure on the national government or Ministry of Health for action. And so when you depend on those bilateral agreements, really the bilateral agreements don't really work. They are just there on shelves, dust is growing, feeling there. But the people on the ground who are faced with a situation are across borders, and they meet every day, and they discuss every day. And so you can actually encourage them to put pressure on their authorities for action. And they are the ones actually at the local level who actually implement the cross-border situations. And so that becomes easy. So meetings work, but I don't believe that we should be in meetings all the time, because meetings don't achieve much. After you have agreed in one meeting, you should go to the field in the bush and do whatever needs to be done. And I think that's what Ethiopia and Sudan did. And that's what peace in Uganda and the Ministry of Health Uganda and South Sudan and DRC are doing. Thank you.
Thank you, Moses. Dr. Frank Richards, please welcome.
Thanks. There are a lot of interesting comments which lead me to make a general comment about the importance of flexibility in programs. I think that's what we're getting into. Matching your interventions with the epidemiology and recognizing that the approach here is getting away from what we often deal with in cookbook sorts of things. Fighting NTDs is a job to be done, but what it is a problem to be solved. Every case is a problem to be solved. And that's why the idea of a flexible approach using all the tools we have in the toolbox. Someone just mentioned doxycycline in Loa areas, once, twice, in the hotspot in Matima, 4 times per year ivermectin treatment, approaches to vector elimination where it's possible, or vector control where it's feasible. All those sorts of things being brought to bear, matched with the epidemiology and the original force of infection, give you an idea of how quickly you can get this job done. And it's not just go and treat once per year at 65%. So I think that's one important thing. The other important thing that I hope we have a chance to get into, and I haven't seen too many questions on this, is the fact that in the new paradigm, you need to have laboratory support. These aren't RDTs that you can do in the field with a finger stick, as we have with LF, or flipping eyelids in trachoma. This is really different, and having a network that supports PCR in laboratories, that supports OV16 ELISAs, has been a very big problem in this. There are backlogs in many countries with dried blood spots and specimens to be done. I think Zerahun touched on it very briefly in Ethiopia, all the DBS that remain to be analyzed. And these are indeed important challenges in this paradigm and to the onco community. Thank you.
Yeah, thank you very much. And now we go to this general one. There is a question on what has been the perception of communities in stopping MTAs. Can we, all the 3 presenters, please respond if possible? What is the perception when you stop treatments? Starting with Peace.
Thank you so much.
Sorry, fine.
Thank you so much. I think this is something we have to think very critically, because it is not all rosy when you stop treatment. There are so many things that complicate the situation. If you like, you can start from the donors and implementing partners. For many people, even though the devil is in the details, they think that that is the end of the road, the business is over and so on, but that is not the case. You can think of recrudescence and other factors. Even in the absence of recrudescence, a district has to be on PTS, then on post-elimination surveillance until the whole country is verified free of transmission. And that is a lot of investment. I don't know how many people, how many partners would appreciate that. That is at the highest level, but we have, like what Frank said, we have to shout loud. And then at the community level, when you herald that they are not going to take treatment, yes, partly it is a relief, but partly because of the very nature of ivermectin, it is not only specific for onchocerciasis, it treats a lot of ectoparasites, intestinal helminthiasis, scabies, name it. So when you stop this, you stop it on the basis of finding with regard to onchocerciasis, but that time would be the best time for the other ectoparasites. So we are very soon likely to be victims of our success. And I am afraid unless we start this work in an integrated fashion with other NTDs and so on, then we'll definitely be going to be sued. So we have to be prepared for that. Thank you.
Thank you, Dr. Tadesse. In Uganda, Peace, what is the perception?
Thank you very much. The perception in Uganda is on two sides, I may say. Some are happy that they have stopped ivermectin and they no longer have the disease, but others still want the medicine because ivermectin was not only being used for onco. Some like the scabies have come back and sometimes the rashes and all of that. And the people would want to still have ivermectin. So they would really, they demand for ivermectin, although they may know that onco is eliminated, but they're wondering why ivermectin should stop. They should say it can continue and then be given for other diseases as well. So it is in twofold. Thank you.
Thank you. The 10 million people stopping MDA in Nigeria, tell us.
Thank you very much. Thank you very much. I share the same views as my two speakers have said. Truly, we're going through very difficult times now because most families now realize that the drug they were on for a number of years had helped in the health status of their wards. And there is now a push from especially communities that are on the border, where the other border side are still treating. And there's a push when they hear there's treatment going on there, they want to go over to get it. So it's it requires a lot of education, health education, and that's what we're trying to do, to get people to understand that yes, we have succeeded in interrupting and eliminating these diseases, and that if you do have scabies, there are other treatments for it. So there's a lot of health education need for us to balance the desire to continue with the vectors.
Thank you very much, Dr. Miri and the rest for the response to this very important question. The communities are the ones we are serving, so it's very important to get and know their perception. We have tried to answer many, I can see most of your questions, and I see even during the talk, some of them were attended. For example, Dr. Frank attended the one on deoxy treatment from Ejong, Delejong, and there is another one. I see this one from Mike French. What is a realistic timeline for macrofilarioside to be available, and what difference would it make to the program? I would put this to Dr. Frank Richards, if you can respond to this.
Thanks, Mike. The macrophil, of course, has always been the holy grail of onco. It's my understanding, first of all, that if you have a magic bullet, that's really great, that would kill the adult worms, but you still have to get people to take the medicine. As we've seen in the United States, we have a beautiful vaccine for COVID, and most people don't, and a lot of people don't want it. And so the transmission probably won't stop and variants could come up. So, you know, I think we always need to be careful on that. As far as the timeline for a macrophil, I was very hopeful that we might have a rapid treatment, doxycycline, if you will, that would be something that would kill the Wolbachia and wouldn't kill microfilaria, so that we could use this in a Loa area, you know, with a short treatment and a sterilizing effect on the worms. They came up with some things. The Gates Foundation, I'm not sure if they're still funding that. Everyone is kind of focusing now on moxidectin, which is not a macrofilaricidal. So I, for one, don't see that as a panacea at this point. And, you know, I don't know much more about it other than I hope using available tools, we can really move ahead on Onco and not be restricted by hoping the researchers will give us something in the near term. Thank you.
Thank you very much, Dr. Frank Richards. I think now we come to the end of our question and answer session. I would like to thank each one of you, the panelists, for taking and responding to these questions, and also the people who asked the questions. We'll try our level best and to respond those who, the questions which have not been answered, and share with you directly. But I would like to thank all the panelists from Ethiopia, Uganda, and Nigeria for the very good presentations, and our panelists, Dr. Nwoke, Kadu, and Moses and Frank, for all the remarkable response and comments to the questions which were raised. Please accept our sincere thank you for this. I would like to now go to the general takeaways of what we have been discussing today, and especially our brief, which we are going to launch in the next 2 slides. So the general takeaways from the 3 countries, we have learned that there is a need to solicit expertise from the national onco elimination committees. These committees are very important, and I think we have heard from one of the chair of this strong committee of Nigeria, how important and how useful these committees have been to the programs. We have also understood from the presentations that each of the foci or focus, we say, is very unique. So there is a need to have innovative ways of implementing the strategies. You cannot have, sometimes you need to have innovations and make sure that you implement strategies in accordance to the focus description. There are geographical differences, there are geological differences, and sometimes even political differences, which you need to take in account while you're implementing onchocerciasis elimination program. The one but not least, this is very important, and I think it's good to all of us note that they need to celebrate the progress, even at the state or focus level. We should not wait till the end, until the whole country has eliminated the disease. It might take a long time. So it's good to celebrate and make sure that the communities understand that they've done very well and the transmission has gotten down. So they have to be confident that they have interrupted the transmission. So please, these are the 3 takeaways from the technical briefs, which I'm supposed to launch in my next slide. Next. The technical brief, which we have written together with the panelists in this webinar, we have put it in our NTD toolbox. This is a link which you can go and make sure that you get this technical brief. It's titled as Reaching the Criteria to Stop Onchocerciasis Mass Drug Administration, and it is found there. So the link is there. Please take it up. I know most of you are familiar with this NTD toolbox, but please make sure you go read it. You can download it and share as much as you can soon after this webinar. Our NTD toolbox is, next please. Our NTD toolbox is an area where you can get most of our practical guidances, tools, and resources working on NTDs. And you can view all these resources either by disease, the 5 diseases, the PC diseases, or you can view the tools by looking at what is the program phase. For example, if the tool you are looking is on planning, then you can click the planning into the programs and the rest. So please open up, and I've seen my colleague have shared in the chat group the link. So please, you can open up and get it uploaded to your resources. I would like to acknowledge the USAID for all the donation it has made through these countries. The Carter Center, as you've seen, most of the work we've been working together with the Carter Center, the Uganda Ministry of Health, the Nigeria Federal Ministry of Health, Ethiopia Ministry of Health, and the endemic communities who have been very, very perceptive of our programs, making sure that they take ivermectin and they contribute towards the interventions. Special thanks to the reviewers of the technical brief, panelists, and all presenters. And I would like to thank you all for being able and make sure that you attend this very important webinar. Thank you very much, and goodbye, and have a nice day, evening, and good morning. Thank you.